Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Laboratory Corporation of America.
Hello, I'm Stanley Cohen, adjunct clinical professor in the Department of Internal Medicine at UT Southwestern Medical Center, Medical School, and director of Division of Rheumatology at Presbyterian Hospital in Dallas, Texas. Welcome today to this program titled Diagnosing Rheumatoid Arthritis Early, Integrating Serologic and Biomarker Test. I'm pleased to be joined today by my colleagues, Jeffrey Curtis, Professor of Medicine at the University of Alabama, Birmingham, in Birmingham, Alabama, and Alan Gubowski, Professor of Medicine at Weill Cornell Medicine in New York, New York. Welcome to both of you. Thanks for being with us today.
It's a pleasure to be with you.
Same here, Stan. Rheumatoid arthritis is obviously the most common form of inflammatory arthritis in the United States and worldwide, and we've learned throughout the years that early and aggressive treatment is necessary, so early and appropriate diagnosis is crucial in improving patient outcomes. Different numbers from different epidemiological studies, about 1.3 to 1.5 U.S. adults have rheumatoid arthritis, about 1% of the adult population, twice as common in females as males. And the onset is most common between age 30 and 60, but certainly can occur at any age. Comorbidities are common with rheumatoid arthritis. We know from studies that cardiovascular disease, coronary artery disease, things of that nature, congestive heart failure is similar to diabetics. Interstitial lung disease occurs clinically in 10 to 20% of our patients and is the biggest unmet need in the treatment at this point. RA patients historically have always had an increased infection risk even before we had more aggressive targeted immunological therapies, higher risk of VTEs, osteoporosis, fragility fractures, disability and functional decline, and an increased risk in certain malignancies such as lymphoma and lung cancer risk. And we know that many of these comorbidities correlate or are associated with higher disease activity. So diagnosing early, treating earlier, can reduce these risks. Rheumatoid arthritis is present for many years before the disease onset. We've known that environmental factors, going way back to miners and silica dust, increasing the risk of RA, to now features such as periodontal disease, certainly smoking in the setting of susceptibility genes such as the DR beta 1 haplotype, and even some changes in the gut microbiome, result in various epigenetic modifications. The most common and most prominent has been protein citrullination, which leads to an antigenic target and again, loss of tolerance by our immune system. Initially, the actions going on in the lymph nodes, the spleen, and elsewhere, but then basically becomes a joint disease in the synovium of the joint. So we've learned a great deal about what goes on that results ultimately in the diagnosis. And again, we're even looking now at developing proper definitions of what preclinical RA is so we can attack it earlier and eventually slow down the disease. So in this program, the faculty, Dr. Curtis, Dr. Gubowski, and I will discuss the role of novel serologic and biomarker tests to aid in the early diagnosis of RA. So I'll be quiet now and ask Jeff, can you briefly describe the natural history of RA and consequences of diagnostic delays on disease progression?
Certainly, I'd be happy to. So, among people who eventually develop rheumatoid arthritis, there's a number of phases. And I think just to begin at the onset of the disease or even risk factors for the disease, I think there's a general understanding that this is an autoimmune disease that occurs based upon some environmental trigger or risk factor in a genetically susceptible host. Now, as a field, we've been searching for decades for what that environmental trigger might be. Certainly, there's a higher risk in smokers, and you mentioned citrullination, and that happens in the lungs of smokers. And there's some strong associations that some of the antibodies that we're going to talk about in the course of this program are citrulinated, and maybe rheumatoid arthritis in some patients begins in the lungs. For others, there's been some associations with the oral flora and the microbiome that occasionally surfaces. But what's interesting is that in many patients who develop RA, you can measure some of the biomarkers that we've come to know and love, rheumatoid factor and ACPA. You can measure those early before people have clinical disease, and in fact, even sometimes in an asymptomatic phase, as much as 10 years before they manifest clinical RA, and their ACPAs or their rheumatoid factors can be positive. Not surprisingly, it's going to be common for first degree relatives sometimes to come to the rheumatologist, and they'll have those autoantibody positive rheumatoid factor and or ACPA and say, I don't even have arthritis, but do I need to worry about this? So the biomarkers can be very helpful to identify people at risk that go on. That said, the concept of pre-RA is a little bit misleading, and as a field, I think we probably want to stay away from that term. Pre-RA implies that just because you're autoantibody positive with some of these biomarkers, that everybody's going to turn into RA, and we don't have that certainty. There's plenty of people who might be rheumatoid factor or ACPA positive that never turn into RA. So I think pre-RA is a bit of a misnomer. To answer the second part of your question, like, why do we care? Why is this important to catch this early? And that's where biomarkers can really help us out. We want to initiate a disease-modifying anti-rheumatic drug or DMARD quickly. People who train maybe in an earlier era, and I remember seeing these in my textbooks of medicine, even in med school, where we had this pyramid where you might start with NSAIDs or sort of less aggressive therapies, and then you would build up to more potent and effective DMARDs with time. I think as a field, we have really turned that pyramid on its head, and we now behave much more like oncologists. We want to come out of the gate with appropriate and aggressive, but appropriate therapy to get control of the disease, because if we do that quickly, that gives people their best chance to go into remission clinically, to preserve their function, and to prevent structural damage and X-ray progression, and to get disease control, ideally in remission or at least low disease activity, as part of a treat to target type paradigm, where we keep adjusting your medicines to get you into that low clinical disease state so that people don't suffer irreversible progression. And doing that quickly and early and getting people diagnosed quickly is really paramount in making that happen.
Thank you, Jeff. Alan, what are the current paradigms for the diagnosis and classification of rheumatoid arthritis? Well, since 2010, we've had a combined classification set from the ACR and UR for the classification for rheumatoid arthritis. Now, a word about classification versus diagnosis. Classification criteria are established to identify homogeneous populations of patients for clinical trials. Methodologically and clinically, they really should not be used diagnostically. And yet, we all do, because we have classification criteria that help us make a tentative diagnosis. But the classification criteria really should be used only in the absence of any other possible etiology that could be contributing to a patient's symptoms. Now, since 2010, we've had a fairly simple classification criteria, which really stratifies the patient and the approach to the patient into four major domains: joints and joint distribution, serology, positive or negative for ACPA or rheumatoid factor, duration of symptoms, and the presence or absence of acute phase reactants. And these four domains have certain point values attached to them, depending upon how extensive, how active, and how many joints may be involved, how long the disease or symptoms have occurred. And if the patient has a score of 6 or more points, they're said to have definite rheumatoid arthritis. But again, the term definite is used in the diagnostic sense, although it really should be used in the classification sense. We also have other test panels that can be used early on and perhaps in many patients during the course of disease as well. But the other tests that have been introduced into clinical practice, such as the MBDA and others, really don't focus so much on classification or diagnosis as much as they focus on tracking treatment response. Thus, they really are not diagnostic biomarkers given the way that we're using them. Jeff, there's been a number of new serologic and biomarker tests have been developed to aid in the diagnosis of patients with RA. Can you give us a overview of some of that data and information regarding those biomarkers?
Certainly, I'd be happy to. So, some of these biomarkers started life, in fact, most of them started life as research tests. But as people have understood, like, what are they? What do they come from? I think they've increasingly entered the thinking of clinicians to say, well, maybe this could be helpful in somebody who I suspect could have rheumatoid arthritis. Let me just cover a couple of those very briefly. One of them would be anti-CAR-P antibodies or anti-carbamylated protein antibodies. These are antibodies that are against carbamylated proteins, which arise when lysine residues in protein are post-translationally modified into homocitrullinine. So that's one example. We have a few others that we could talk about that, again, are available in some labs to check. So, for example, if we wanted to talk about the 14-338 eta test, so this is a family of proteins that consists of 7 isoforms. It's found in patients' bloodstream, and the biologic processes that underlie them are linked to the inflammatory process. You can recover these both in blood and synovial fluid. And these, like most of the biomarkers that we're talking about today, typically add sensitivity to testing. What do I mean by that? Sensitivity meaning you might test somebody who, and they are found to be rheumatoid factor and ACPA or anti-CCP negative. So we would normally call that seronegative. And then we're kind of scratching our heads a little bit saying, well, are we sure this is rheumatoid arthritis? And that's where some of these new antibodies like anti-CAR-P, 14-338 eta, and others come into play, where if you test those, many of them have higher specificity, meaning you're going to be less likely to have false positives. They're more specific for the disease, and they may add 10, 20, 25% sensitivity, meaning some people are going to be positive for these antibodies that we don't traditionally test for, but now are commercially available, giving greater confidence that, yes, this is really seronegative RA, and that we would treat this like rheumatoid arthritis. And I think that can confer greater confidence to use DMARDs, biologics, JAK inhibitors when these are positive, even though rheumatoid factor and ACPA might be negative.
Yeah, I agree with Jeff on that. I think we're learning that these newer antibodies that are available to us may be helpful in perhaps further subdividing our patients who are seropositive or seronegative and following them prospectively to see what extent we're able to influence therapy as a function of having them available to us. And again, it looks like that some of these novel biomarkers are also associated with greater disease activity, greater likelihood of erosive disease over time. And, the finding of those certainly would be a signal to us as providers, clinicians, to be more aggressive. We have this whole pool of seronegative patients. And Alan, I'd like you to just talk a little bit about your experience with seronegative patients. Are they similar to seropositive patients? Do they differ? Early in my career, seronegative RA was felt to be more of a benign condition, and they really didn't have the course of seropositive RA. To me, that's totally incorrect at this point. So I'd like to hear from you, and then also from Jeff, about your thoughts on the differences between the phenotype seropositive and seronegative patients. Well, the first thing I would have to point out, Stan, is that the ACR-ULR 2010 classification criteria, which include a domain of assessing for seropositivity or seronegativity, are not really reflected in the subsequent ACR recommendations about management. It's not that clear that we need to treat a seropositive rheumatoid that much differently from a seronegative rheumatoid, although the ability to use these newer antibodies that we have available to us may change that perspective as we get more data on them as patients are followed prospectively with them. One of the challenges, as you point out, of course, is that when you do your initial assessment, for whatever reason, the patient may in fact be seronegative. And then for whatever reason, a repeat test resorted on the next visit And lo and behold, they're seropositive. So we have this concept of seroconversion that we have to deal with as well. And that's where these newer antibodies that we're talking about that Jeff has alluded to may come in quite handy. Clinically, the cohorts of patients can be somewhat different in that patients who are seropositive are thought to have higher disease activity, increased joint damage, a higher risk of complications, a reduced likelihood of being able to get them into remission, and a need, as you pointed out, for more aggressive treatment. But remember, those are statements that are being made based on populations of patients and cohorts within those populations. And for any individual patient, those generalities may not, in fact, be the case. Jeff, do you have any thoughts on that?
Yeah, I do. So I think that I would agree with Alan that the concept that, oh, you're seropositive, I'm going to treat you in a different way has kind of been debunked. I think we need to be treating people as aggressively, regardless of whether they're seropositive or negative. That said, I also agree that the literature is pretty consistent that if you are seropositive, you probably are going to have a somewhat expected worse disease course with more severe disease, maybe a little bit more refractory. Some of those studies are a little bit inconsistent, but in general, I do think that that heralds a worse prognosis and maybe more difficult to treat rheumatoid arthritis. If we were to talk about downstream of a patient's journey, if you're strongly seropositive, it makes it a little bit harder that you could peel back therapies to monotherapy or even drug free remission. That's not that common in RA, but it's even less common in somebody who's strongly seropositive. And we've seen some of these same disease associations with some of these newer antibody tests. For example, PAD4. So this is one of those that has left the research space and now has entered the commercial testing space in many labs. So protein arginine deaminase, or PAD4, is one of the members of the PAD family. Five have been described in humans, three of them, PAD2, 3, and 4, as autoantigens in rheumatoid arthritis. And interestingly, anti PAD4 antibodies are found in about 30 to 40% of RA patients, very high specificity, greater than 95%. And if you said, well, I've got somebody who's seronegative, what's the likelihood they might be PAD4 positive? It's definitely not zero. There's not perfect correlation. Maybe 2 to 20% of people are going to be positive for PAD4 that are seronegative, negative RF, negative ACPA. So that's helpful because it's going to help identify people that really do have RA in a more specific way. But getting back to your question, if you're PAD4 positive, that is associated with a higher risk for joint erosions and a more severe disease phenotype. And as many may know, there are some therapies in development where actually PAD4 is the target. So we may see some treatments that specifically target that pathway, not just as a biomarker, but as a therapeutic intervention. So I think there's a lot going on here with that mechanistic pathway, both as a biomarker and perhaps eventually as a treatment target.
Well, all of these novel biomarkers really do highlight a new understanding of the disease process as well. And I think the paramount thing, which I think we as rheumatologists are good at doing, is differentiating seronegative inflammatory arthritis from other things such as polyarticular gout or chronic pseudo gout, which can be difficult. And having the availability of these other novel biomarkers can certainly help us hone in our diagnosis. So let's shift gears a little bit. And we've all, opined about how important it is to make an early diagnosis and initiate aggressive treatment early in hopes of inducing low disease activity or remission. But we know that's often not feasible because we have a workforce shortage in North America. And I ask both of you, do you have any thoughts on what we can do today and what we might be able to do with the AI and machine learning in the future to try to improve access from primary care to specialty care for the management of inflammatory arthritis? So, Alan, I'll have you go first, and then Jeff second. Sure. One strategy that we've been developing, and the ACR has taken a leadership role in over the period of years, is educating the primary care physician really to differentiate between mechanical pain and mechanical problems, inflammatory pain and inflammatory problems, and widespread pain and widespread pain problems. And I think those really can be considered three general buckets. And if in our efforts we can get the primary care physician to recognize that difference and understand if a patient with inflammatory disease has a different set of potential outcomes than the other two and get that patient to us early, then that will assist the patient as well. So, strategies to educate the primary physician about what the most appropriate patient to refer early really, I think, is helping.
So I appreciate that comment and the ask. And I think that more effective triage to get the patients in to see rheumatology that we can help the most is critical. I can tell you where I practice in Alabama, within my own university, most of the referring physicians are pretty good when patients have suspected rheumatoid arthritis at checking a rheumatoid factor and CCP antibodies. But most of my community referrals, I rarely ever get both of those things, and sometimes I don't even get a rheumatoid factor. So here's where I think that testing those autoantibodies can be helpful. And frankly, if some of the more novel ones that we've been talking about, things that are a little bit more specific than, say, rheumatoid factor, and increase that sensitivity by another 10, 20%, like if the arthritis panels or the things that were checked were the newer autoantigens that we can now test for, frankly, that would get my attention, Alan, in the same way you described. If somebody says, look, they're RF or ACPA or 1433 positive and they have small joint pain, I'll stay late for that and I'll be late or miss my next engagement because that's the kind of patient I can help. But if you just come to me with none of that, then non-specific positive ANA joint pain, the certainty that that's really bona fide RA is just a whole lot less than if I have some of these highly specific autoantibodies that are checked and positive. One last topic, and you mentioned AI, and here's where I think AI could make helpful suggestions or recommendations based on evidence about what might be checked. And I think some of the antibodies we've been talking about that, may not be familiar or within the parlance of referring physicians. That's where I think AI can be helpful to make suggestions based on clinical presentation, even to help optimize those referrals. So I think that is an important role to help initially phenotype patients and even make recommendations on what to check before or at the time of referral. So I think that's a very valuable role for AI in large healthcare systems and population screening, where there's a clinical suspicion, but there are some confirmatory and specific lab tests that can help us out, like those we've been talking about.
And I agree with all the comments, but I am hopeful in the future that with AI and machine learning, that at least in integrated healthcare systems, that we potentially could identify people early in their disease process and help the triage system rather than what we've all been trying to do on our own for the last several years. So let's do a case study sort of to highlight some of the points that we've discussed up to this point in the presentation. So this is a typical patient that we see in the practice, 44-year-old female that happens to be a teacher. And she presented to her primary care physician, 6-month history of joint pain and stiffness, gradual onset of symptoms, intermittent discomfort in her wrists and fingers. And over the last 2 months, the pain has become more persistent, symmetrical, involving both the wrist, MCPs, and PIPs. She reports morning stiffness lasting about an hour and a half, difficulty in her activities of daily living, buttoning her clothes, and also intermittent swelling in the knees, particularly after inactivity. Her past medical history is really unremarkable. Mild seasonal allergies, no family history of autoimmune disease. She herself has, as part of our rheumatic review of systems, no other things such as oral ulcers, Raynaud's, alopecia, photosensitivity, things of that nature. She is a non-smoker. On physical exam, she has some MCP and PIP swelling and tenderness, a little bit of synovitis in the wrist, and a small effusion in the knee. She has no skin rashes, no nodules, no psoriasis, no nail pitting, and no gouty tophi. Our lab findings show a mild anemia, most likely anemia of chronic disease, elevated acute phase reactants, and she's seronegative for rheumatoid factor and ACPA. She has no erosive disease on x-rays, which we obtained for baseline evaluation. So I'm going to direct the first question at you, Alan, and then Jeff will also chime in. Would additional laboratory testing help you with the diagnosis of this patient? And if so, what additional lab testing would you consider? So, Stan, I kind of score the way you did, maybe a little bit more closer to 6 because of the imaging studies, which you did have, and the fact that she had something that we've really abandoned since 1987 criteria, namely the morning stiffness. So I think she does have rheumatoid arthritis. And I would point out, of course, once again, that the 2010 criteria do not need a positive rheumatoid factor or positive ACPA to make the diagnosis. That said, I think I might be interested in having one of the additional serologies just to make me a bit more comfortable before I launch into the kind of aggressive therapy that I think this woman is going to need in order to calm her down early and thus improve her ultimate outcome and reduce the possibility of the comorbidities that you alluded to early, in particular the comorbidities of or undertreated inflammation, such as malignancy or cardiovascular disease. So I think in this particular instance, I would be helped along by having those other antibodies available to us because I think it would just give me a greater sense of confidence of where I think this woman is going to go. Jeff?
So I would mostly agree, although I'm also comfortable calling this seronegative RA because, Stan, you described as someone with a chronic bilateral symmetric inflammatory polyarthritis. And in the absence of other strong risk factors for the handful of other things that behave like that, I'm pretty comfortable saying, yes, this is seronegative RA. That said, make her 10 or 15 years older, give her chronic disease stage 3 or 4, make it more unilateral rather than bilateral. Now I'm somewhat uneasier about doing that same thing. And then I even more agree with you, Alan, that probably checking some of these expanded antibody profiles that we've been talking about, like 1433 eta or anti-CAR-P, may really be helpful because if they're positive, then I'm much more comfortable calling this seronegative RA. One last point, Alan, you mentioned a few minutes ago this idea of seroconversion. Whatever you chose to do with her, I think it's entirely possible that 6 or 12 months down the road, if you rechecked her RF and ACPAs, they might have turned from negative to positive. I don't keep doing that again and again. My sense is that if you're going to seroconvert, you're going to do it within about the first year or so after clinical onset of symptoms. So I often will recheck down the road once, but that expanded antibody profile may give us greater comfort to start DMARDs more quickly, even for somebody like this, that we do have pretty high suspicion this is really seronegative RA.
Thanks, Jeff. So in this particular case, further testing was done, and she was 1433 Eta positive as well as anti-CAR-P. So it helped to cement the diagnosis. And I think the biomarkers and their patient for diagnosis is going to continue to improve as we have greater understanding of what's going on in the pathogenesis of the disease, and rather than the phenotypic description that we presently do. So I think there's things to come that are going to help us as far as identifying patients earlier and earlier and discriminating from other diseases. Well, thanks to both of you. Terrific half hour having this discussion. And I also want to thank the audience. So thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.